Session 12 is about care workflows. We start by sharing our insights about scheduling, then we review patient flow in the clinic, and wrap up the session on discussing the bad and the ugly of inbox messaging, which has been a sore spot for many clinicians.
The first workflow is scheduling. How a primary care doctor's day is set up is incredibly important. In the fee for service system, the doctor needs to make sure that they see enough volume every day in order to keep the lights on, support their salary, and to support the staff. One of the biggest keys to scheduling is optimizing the number of people, and part of optimization is predicting the number of no-shows. There's a thing that most offices will do, which is called double booking. One same 15-minute time slot, two patients will be placed, and this is to anticipate a certain percentage of no-shows. And there's actually AI out there that will score patients based on their likelihood to no-show to help a practice optimize who to double book and when to double book. In order to prevent no-shows, most practices will have late and no-show policies, usually involving some sort of financial penalty for not showing up. And frequently, because of the double booking, doctors will run behind. If a patient is late, they might even lose their spot in line. And with most traditional fee-for-service practices having several months or weeks of wait time, it hurts to show up to your visit maybe 15, 20 minutes late to be told that you have to wait 2 weeks. But there's no good way, because if the doctor is running late and you show up 20 minutes late, that kind of forces the schedule even further later. So offices that have to maximize the number of patients seen a day generally will also have to enforce fairly strict late and no-show policies. The other big factor of scheduling a day is the type of visit. There's the quote physical exam, and doctors try to limit those because they, in theory, take a lot longer. Actually, the last time that I saw my former PCP, I was told the next physical exam appointment would be available 11 months from when I called. So that just shows you the degree of limitation fee-for-service offices have. Most offices will have some sort of urgent care or acute care slot that they leave open. A lot of times, depending on the practice, sometimes these acute care visits will get filled with chronic care anyways, because the chronic people want to come in, and the acute care is always variable, so they might not get people. But anyways, most practices will leave some sort of slots open, ideally set for acute care. And then in terms of chronic patients, generally there's the 15-minute slot, 20-minute slot, or 30-minute slot, allowing for about 7 to 15 minutes total of face-to-face time with the doctor. And this is usually determined by the schedulers, but sometimes by the doctors, who say, hey, this is a complicated patient, give them the 30-minute time slot, versus, okay, this is going to be quick, 15-minute time slot is fine. In terms of how to schedule, this also varies amongst practices. A little old school is the phone, where the patient calls in and talks to the scheduler and puts themselves on the schedule. They go back and forth talking to a human who tells them what the availabilities are, and then they sort it out over the phone. There is direct scheduling, which is where the patient will go onto the website and pick a time themselves. And then with some clinics, there are walk-ins where the patient can just show up at the practice, and there's some wiggle room allowing for that. Or if it's really severe, the doctor can squeeze them in between some chronic patients. Of note, ZocDoc kind of falls into this workflow in terms of schedule optimization, because the way ZocDoc works is they list doctors' schedules and allow patients to self-schedule with doctors' offices to fill in unfilled spaces. Duration of office visits usually is about 10 to 60 minutes, depending on the practice. There are studies that show the doctor only has about 50% of the time talking to the patient. So in a 10-minute visit, it's really only 5 minutes. 60-minute visits tend to be pretty rare, reserved for physicals or Not even really procedures. Primary care procedures tend to be pretty quick. It's really for the complex, complicated patient. Ironically, this is a little misaligned incentive. The older, sicker patients, whether they're on Medicare on the older category or sicker being in the Medicaid category, the people who really need the most time, those are the insurances that pay the least. And so it's really hard to take care of those individuals. But in general, 15-minute visits, 7-minute doctor time. In value-based care, it's a little different. DPC concierge, value-based, all have about 30, 60 minutes where the vast majority of the time is used in face-to-face interaction. One Medical and ChenMed both have predictable schedules. One Medical has 30-minute visits across a 8-hour day, so 16 slots total, and that's all they do. And it's fixed, doesn't change. ChenMed does 30-minute visits as well. They do 20 visits a day, and it's mostly focused on face-to-face time. The next workflow is patient flow. We've got the patient scheduled. Now they're here. What happens next? Traditional fee-for-service, most commonly, patients come into the waiting room. They sit there, fill out their forms, give their insurance, pay the copay. If a doctor is really good and stays on time, the patient has limited time in the waiting room. Then from the waiting room, a patient gets brought back into the room. This involves stopping by somewhere to get vitals, get weighed, blood pressure, all that stuff before the doctor comes in. And after the patient's been roomed, which is chief complaint on the chart, vitals done, they sit and wait. Now, what the patient sees is they sit in the room after the medical assistant or the nurse or whoever takes their vitals. It sometimes feels like a long time. What's happening on the outside is a doctor will usually have multiple rooms that they are running back and forth between. And a patient will get roomed when a room opens, not when a doctor is ready and waiting to see them. The doctor might have two patients ahead still to be seen as the patient's getting roomed, which is why sometimes it takes time. Not to mention, there's the time to put in orders. So doctor has to do the patient encounter and then put in the orders and do their note. Some doctors will do it sequentially, so they'll see a patient, they'll put in the orders, they'll do their note, move on to the next patient. Other doctors will try and do multiple rooms at a time, typing some notes and setting some stuff up, and then put in the orders in batches as well. After the visit, there is the follow-up. So the follow-up is interesting because there's a little bit of disconnect between what a doctor says and what the front desk has. So one example, a friend of mine went to go see a specialist. The specialist says, "This is something urgent. I need to see you back in 2 weeks." My friend goes up to the front desk and the front desk says, "Okay, this doctor's next available appointment is in 3 months." And there was nothing he could do about it. So he wasn't sure if it was urgent or not. And frequently in primary care with chronic disease management, if a certain chronic disease is starting to get out of control, we generally prefer for the patient to come back sooner, but due to scheduling issues, the patient might not be able to do so. And that's where these value-based models come in. The idea is see fewer patients, give them the availability that they need and the flexibility for the doctor to bring the patient back sooner as needed, rather than cramming the schedule chock full of people every day to where there's no breathing room for months, which is generally what's seen in the traditional fee-for-service office. The final thing, which is a pretty big topic, is inbox management. Primary care has the distinct privilege of responding to everything and anything. When most patients have questions, they get to message their doctors, usually through some sort of patient portal for most private practice and hospital systems. Responding to inbox messages usually happens during the workday, but also during pajama time. Some practices will allow for, quote, protected time in order to do admin work, which is to sit there and respond to patients and fill out paperwork. There's been a little bit of pushback from the medical system post-COVID, because during COVID, there was just so much more, quote, telemedicine where patients and doctors messaged back and forth, did calls on the phone, did video visits, but patients have gotten used to it and they've been essentially spamming the doctors a lot more with questions and requests. And so certain Hospital systems now will charge per portal message. And this has gotten some very mixed reviews from both sides, some very strong feelings about whether this is ethical or whether people should allow it. Of course, the people who support this feel overwhelmed, feel they're not valued for their time when they respond for free. The people who don't like it say this will hurt the doctor-patient relationship. Now more people will not get care or stay away from the healthcare system because of lack of access and availability. In larger practices, a lot of the inbox messages will be triaged, meaning the messages will hit the nurse's inbox first, and the nurse will try to respond as much as they can. And the ones that require a doctor will get escalated to the doctor, thereby saving the doctor from an influx of a bajillion messages. These inbox messages generally can be a whole gamut of things, from refill requests to asking to get scheduled to paperwork to general medical questions. Most doctors will also have a physical inbox or mailbox where they have to deal with a lot of clerical paperwork, some of which we mentioned earlier: prior auths, denials, physical refill requests faxed over from CVS or some other pharmacy, or insurance companies sending reminders for us to do our job better, which we generally love to get. And then, of course, is the never ending sales material from vendors and drug reps. On the more internal side, some hospital systems have internal messaging between doctors. Inbox messages can involve messages from specialists or colleagues. And now, actually, some of the larger EMR systems have chat functions where doctors can have off the record conversations with each other and do what we call, quote, curbside consults, where we just ask questions to each other or to specialists without making it an official consult or putting anything in the medical record. And then outside specialists, the virtual messaging and chat are usually for doctors within a hospital system or a network. If it's outside, then you'll get paperwork from the specialists, usually by fax or sometimes even by snail mail. One of the perks of having the chat or a quick internal inbox is being able to ask quick questions and having updates on patients or results. But one of the things that people don't like about having more access is very much similar to just society in general, and having the phone at all times is, sure, you can respond faster, but you're constantly being interrupted all the time. In the middle of a patient encounter, you could get a ping from somebody asking for something, or, if you have poorly trained staff, the staff might be asking you questions when it's not the right time, or it might not be as important. Whereas before, if you had to call the doctor, you would think twice about doing it, but now it's just a simple chat. A lot of people don't feel as shy about firing off the message. The final thing to bring it all together in terms of the care flow is looking at fee-for-service versus value-based care. Fee-for-service being a volume-based model, optimizing the scheduling creates very little breathing or wiggle room for urgency, for acute care, and makes it very hard on the patient side to get in when they need to. When you see so many patients in a day, that also becomes proportionate to the number of inbox messages you get, which can get pretty overbearing for a lot of doctors. When you switch to a value-based care model, the volume drops, the inbox messages drop, and everything that's done is valuable to the patients. The longer visits, patient can get in when they need to, and all the paperwork, conversations, and stuff are all part of the provided care that's all, quote, paid for in the capitated model, whereas in fee-for-service, none of the inbox messages are paid for. And so people have to talk about charging and how much to charge and when to charge, making it very complicated. This is a general overview of what happens from scheduling through the patient visit. But of course, every practice is different, has their own flavors, and depending on the payment model, it also varies.
To summarize, we discussed intricacies of patient scheduling and reviewed how patients move through the clinic, interacting with different components of the care journey. We finished the session with our insights about inbox management, which is a hairy topic these days and has been fueling innovation in the space. This concludes session 12.